and the strategic plan within the infrastructure that Margolis is developing in collaboration with, again, this unique and tremendous set of resources that is Duke. I have a few minutes now. Questions about what you've heard, things that we're missing. Hopefully this discussion is starting to inspire some new ideas and new project directions that we can undertake together, very much along the lines that Peter was just describing. So any comments, questions, thoughts at this point? Very patient audience for today. All right, well, I want you to hold that thought, and I'm going to ask that same kind of question to the people who are coming up for our final panel of the afternoon. I think we've got everybody here, even though we're running actually a little bit ahead of schedule. It's also a unique event. I think this is also a Duke characteristic and reflects Vicki's organizing. The most number of people I know speaking in the least amount of time while still staying on or ahead of schedule. So I'd like to ask our final panel for the afternoon to come up. This is our what we're calling our One Duke panel. You'll see here people who you've heard from either directly today or who have been very much involved from the start in the development of the center because it is being done in collaboration with a lot of leaders and experts from around Duke. I don't think I need to give this group much of an introduction, but you all heard from Krishna Udayakumar earlier, who's heading up a new center in collaboration with the Margolis Center and Global Health on innovation and policy. Eric Huang, who many of you know, not only a leading surgeon, but a leader in health informatics and finding new and better ways to bring data together and use it effectively. Adrian Hernandez just gave a great presentation reflecting some of the leading work that he's doing with National Distributed Research Networks as Associate Director at DCRI. Leslie Curtis, the new director of the Center for Population Health, is going to be an integral part of the medical school and reflecting the shift that's taking place here at Duke to put more emphasis on the population health themes that we've talked about from a policy standpoint today. Dev Sangvai, who leads the efforts at Duke Health around moving towards more accountable population-based approaches to delivering care right here in Durham and the Duke system. And Larry Caron overseeing research in the Duke ecosystem. And Larry, if you don't mind, I'd like to start with you. One of the big themes from today has been about developing and applying data to questions of relevance to policy. Duke is, if anything, known for being a data powerhouse, has been leading the way in a lot of clinical research areas and a lot of other areas of academics too. But it does seem like there's more that can be done, and that what we're trying to support here in these policy applications of building out the data ecosystem at Duke is something that I think could have benefits for other parts of the university too. So maybe you could spend a minute or two telling us about where you see us now in terms of the Duke data ecosystem and how it can grow out and how we can support that.
Okay, so you know, we talk about health policy and policy driven by evidence, right? So a lot of that, of course, is data. And so out of the strategic planning process that Dr. Washington ran, one of the things that is coming together is a partnership between the main campus and Duke Health around what's looking to be a new center in data-driven health solutions. And so this is something that will bring together quantitative scientists from the main campus primarily, and of course clinicians from the health system to address important questions that are driven by analysis of data. And so as part of that, we need an infrastructure that supports that research. And so we have a very big and successful health system, and to support that, there's a significant IT infrastructure that has to work every day, every minute. But the research operation also needs an IT infrastructure to make it easy to grab data and ask questions of that data. So it's really kind of a different infrastructure from running a hospital. And so this is something we do actually need to get better at. And so we hope that through this center and through leadership of a lot of people on this panel, we hope to see that happen.
Great. Thanks, Larry. And stick with the focus on data, and now maybe turning more directly to the Duke Health piece of that, Dev. Maybe you could talk a little bit about the work that you're doing on moving Duke in the direction of care redesign that I think very much resonates with the themes that we've been talking about all afternoon, and how the Margolis Center can potentially help support these overall goals.
Definitely. So I think we've heard a lot about data today, and I think the other set of data we do have are claims files. We do a lot of work with payers throughout the state and government payers as well, who provide us with claims data for the purposes of improving healthcare. But I think there's real opportunity to think about how we use those data to get smarter about understanding variations in care, doing some predictive modeling, and so forth. The other opportunity I think we really have, and what's really encouraging about the Margolis Center is we've heard bits and pieces today about how to make decisions. Because I think one of our biggest challenges are we think we need data, we think we need to find a way to present it, and we think we need an aha. And then we need to present that aha to the decisions makers, and they're going to naturally accept it and change the way they behave. I think we have to match data with how to get payers and providers to change behavior, in particular providers. Because just presenting data to a physician, for example, I'm a family physician. If somebody told me who are my 50 diabetics who are most out of control, I'm going to tell you, you can put it on a nice display, a great dashboard, but the first one might have a transportation issue. The second one may have poor health literacy. The third one has another issue, and so forth. So the data alone aren't enough. We need to be able to present the data in a way that's meaningful, and we need to simultaneously develop those workflow solutions that allow us to do something with those data. Which is why when we heard about the term Living Lab, I'm really encouraged by taking the power of the Margolis Center, thinking about where we deliver healthcare, and really applying that Living Lab concept. Because the data are only as good as the workflow solutions that you have to do something with them.
Great. Thanks, Dev. And Eric, maybe I can turn to you next. You're also working some within the health system, but you've also pioneered some new ways of thinking about data as we move into an era of more distributed and cloud-based systems. So your thoughts on how those kinds of trends fit with what you've heard about today?
Certainly, to extend on what Deb was talking about, one example is an application that I've been working on where we use applied machine learning to make predictions about surgical complications, and also trying to think about how that knits into the actual surgical workflows on a surgical ward. The thing about that project that's interesting to me is that in theory, what we do is we're using machine learning to make a prediction, and then we're also associating that prediction with interventions that can potentially, take place on the floor. And when you think about the business case for that, then you start wondering, okay, so who's the right customer for this kind of thing? If you think about in terms of the health system, currently in the fee for service world, it actually doesn't make sense from a business sense. Even though we know we're doing something that's good, right? If you're going to prevent surgical complications, that's undoubtedly a good thing. But the incentives are misaligned in that case. So one interesting thing about this project is, okay, then how do we need to think about how we incentivize actually reducing surgical complications? Obviously, a fee-for-value type system, in terms of postoperative care would be more beneficial and give a better business case. But if you're going to go present this to a bunch of CIOs across the country, it's probably a no-go right now. So that's where policy is going to be really important for connecting what should be great technology that improves patients and providers, well-being, and that's where policy really needs to help us, on the technology front.
Right, some good opportunities there, and Leslie, on kind of a related topic, the Center for Population Health is really all about this, about identifying better ways to keep populations healthy, including medical interventions, but also the broader range of things that aren't traditional medicine that we've talked about some today. And it's also going to have a big data component there too. Could you talk a little bit about how you see the Center for Population Health going forward, and how it can work with the Margolis Center?
Absolutely. Well, we've been having this conversation for, it seems like a year now, haven't we? So it's just terrific to be here today and see how things are moving along so quickly. As many folks in the room may know, the Center for Population Health Sciences, in its mature state, isn't intended to be a center, but rather a department in the School of Medicine that will really be an academic home for the non-clinical faculty, many of whom we've heard from today, who really drive forward the science of population health. As Mark alluded to, that requires absolutely a data infrastructure. I think much of that has been discussed today, and we're really pushing hard to not only use claims data and clinical data, but to put them together so that we can leverage those sources together. And it's been exciting to work with Larry and others to move that along. I think one of the other clear, slightly longer term opportunities for the Margolis Center and eventually the Department of Population Health Sciences is really to begin to attract and recruit more faculty in the areas of health policy, health economics. As folks in this room may know, that can be a challenge it has been a challenge to recruit those kinds of folks when there is no sort of formal academic home for them in the School of Medicine. So I think the opportunities are just, honestly, limitless.
Great to hear. And Krishna, you've got an international perspective on this, having extensive experience with different parts of Duke that all have a bearing internationally. Duke Health, which is now a global presence directly, the Global Health Institute, and the work on innovation in health that you've been leading as a nonprofit collaboration with the private sector, and now the new center that's combining innovation and policy. Maybe a bit of your perspective on this. It's not just about data, but it does involve really getting more empirically relevant evidence globally.
Yeah, absolutely. I think we're building on a lot of strong global engagement and seeing a lot of the resources that the Margolis Center has been able to coalesce very quickly and integrate in ways that we have not been able to institutionally it certainly makes me very optimistic about the opportunities to have global impact, in that a lot of the work that we've done in the global engagement space has been descriptive or qualitative in its approach because of a lack of evidence and data sciences in that space. And I think one of the opportunities we now have by leveraging the breadth of resources at the Margolis Center is really then to bring all of the quantitative expertise that you see represented here next to me and across the audience here, and bring that to bear so that we are helping others to generate the best evidence about creating value in healthcare and biomedical sciences, and take those lessons learned and hopefully start applying some of them back to continue to better reform our systems here. So I think there are opportunities for innovation and impact in the short term that may be more in the global space than in the domestic space, based on the specific engagements that we already have up and running. But it, to me, is really just about bidirectional learning and applying all of the capabilities across Duke to have broader global impact.
Mm-hmm. And Adrian, just to pick up on a theme that you emphasized, you're leading, helping to lead some of the biggest so-called distributed data efforts around the country, and in some cases with DCRI internationally. You emphasized the opportunities for turning a lot of this data into evidence, but you also emphasized some of the challenges. I mean, it takes governance, it takes getting people aligned, it takes, I struck a nerve there. But, how can we help overcome those barriers?
Yeah, this is where Margolis Center comes into play in a very clear fashion. One of the things that we're actually realizing, and I just highlighted this earlier, is that the technical capabilities of bringing health systems and having their data mapped to a common data model is definitely possible. It's actually just been done, thanks to Leslie. So now that we have all these health systems that have come together with various data marts on literally over 100 million people, how can we actually use that in the most efficient and effective way with united goal of improving healthcare and outcomes? And also doing that in partnership with major groups that need this evidence to make decisions. So FDA, Medicare, payers, clinicians, et cetera. And so this is where we see, we've already seen this, Margolis Center is starting to drive the not only identifying the questions, but actually, more importantly, not just saying what the questions are, but here are the approaches and bringing people together so that they have a common goal. And so over the next year, I think this will be front and center, actually, regardless if you're a Trump or a Clinton fan here. This will be something I think, hopefully, that the Margolis Center will be able to answer and actually bring people together. And so we'll see, and we're going to leverage this, hopefully, in systems like PCORnet, where people sometimes need to really see what's the kind of broader goal in 5 years.
Yeah, I mean, we laughed a little bit when you started talking about how challenging it is to bring these different enterprises together. But again, one of the unique features of Duke is it's got a foundation for doing that here within the university, university-wide, across these academic institutions nationally and globally. And we certainly intend to build on that. So I'm going to go off script now and ask one actually a two-part question. I'm going to go down the line. Maybe Larry will start down at your end. So you all have had a chance to help with the development of the center and the strategic plan over the past 6 months, or in the case of Leslie, we've been talking about this for a year. You've been involved in some of our key initial projects. Just would like to ask, tell me about one thing that you've heard today that you want to make sure we pick up on and run with. And we've been talking about the data issues, so you can build on that if you want. But the one thing you'd like us to pick up and run with. And I'll tell you, after we go down the line with this question for all of you, next question is going to be, what's your question or challenge for us? What should we take up next? But let's start with where are we on the right track and need to keep building on it.
So I think I'll pick up where Adrian left off. When you talk about 100 million patients and those types of records, that's just an incredible opportunity. And happy to see Cherry Ryder from our stat department. It's a tremendous opportunity to bring all of Duke together. MDs like Adrian, experts like Leslie, who've been working this for I think decades. And also,
that may be one of the quotes of the day now. Okay, I'll have to get a vote.
One or 2 decades. So, but in any case, there are tremendous opportunities for data scientists to play in this, and so one of the things I really hope to see as we move forward with the center is to bring all of Duke together, data scientists in particular, and bring them together with the subject matter experts. I talked with Rob Califf about this kind of space before there was the Margolis Center, and Rob always talked about the importance of bringing subject matter experts, clinicians, together with the data scientists, because data scientists by themselves are very likely to discover things that are well known, but interesting, but perhaps well known. And so having the clinicians and also the policy experts drive the questions of the data science, I think, is really exciting, and I think it should hopefully be a priority.
Dev, what did you hear today that you want to make sure we build on?
So I think that what we've really captured here is one of the challenges on the delivery side. It's hard on the delivery side to think about care redesign and how you might inform policy, and oftentimes our desire to do care redesign is informed by more regulations than what policy might be. And I think sitting here this afternoon, I heard several, but I'd just like to highlight 3 where I think we've hit on something really interesting here. The Bass Fellows and the work they want to do with Medicaid. Many of you might know that the health systems in North Carolina are actually thinking of launching a Medicaid health plan. So what phenomenal opportunity do we have to learn from something like that? The work Peter is doing around understanding consumer behavior, we know from our own experience that we have patients for whom we're responsible who really don't know what they've purchased off the health insurance exchange and often look to us to help them understand their benefits. How powerful is that we can now think about that interface and continue to develop that? And then we also heard today on a number of times about the cost of drugs. When we look at the accountable populations we have, no surprise, the single line items that's growing the fastest, probably the hardest to bend, is going to be around drugs, particularly specialty pharmacy. So our ability to think about alternative payment models that we might want to get into because we have the intel knowledge and the guts to do it because of something like the Margolis Center, it's really exciting.
Thanks. Leslie?
So I'm reflecting back to maybe the very beginning of the day when Dr. Margolis talked about this world where somebody picks up the phone and calls an expert in a health policy kind of topic, and it's somebody here at Duke, nowhere else, right? And as I listened to the presentations today, it struck me that needs to happen. It could happen today, right? So I think that's just a huge opportunity for the center, and I have no doubt that it'll achieve that.
Okay. Great vision. Thanks. Adrian?
Yeah, so one of the things themes that I picked up on was how this can be the concept of actually really testing out and learning from multiple health systems. So not only within a Duke Health system, but across other health systems. So we actually are establishing what the model is, actually generating the evidence, and then actually feeding it back to policymakers and then learning from that. And so there's probably no other place that could pull this off except here. And so just hearing Michael from Dell Medical School is kind of an example where I can have this dream that, like, if we could actually get multiple health systems that are actually working together and recognizing that they can do this in a pre-competitive space or not in a competitive way, then everyone will win. And so this is a way to do things across the nation, leveraging multiple health systems and doing health system research and or creating multiple living labs.
Great. Thanks.
I wanted to actually extend upon points that Larry and Adrian have been making in terms of, talking about how, individual health systems collectively can contribute to data. I was sitting at lunch with Robert Calderbank, so who better to talk about data with, and he was talking about, how there are two approaches to answering problems. You can have a theory, and then, you take a top-down approach and try to gather the evidence to support your theory, or you start with the data and then, ultimately find a theory. Now, obviously, you don't want to fall in the trap of not having any hypotheses about anything at all, but I think healthcare is a good situation where, for instance, 30-day readmissions, we have this metric out there. And, that was probably done in a little bit of a command and control way. So what about thinking about if different health systems with different case mixes, different populations, what if we actually could use the data to help us understand whether, for Duke, maybe it's 46-day, readmission, whereas for Cleveland Clinic, it's, 57. Now, I'm not trying to say anything about any of those systems, but, just thinking about how different it might be. So, right, because that's really using, I think all of us understand that readmissions is probably a good way to think about, a quality metric. Certainly people can argue about that, but maybe we should use the data to actually be a little bit more fine-grained about using those kinds of quality metrics. And that's where, PCORNet and all these academic health systems and private health systems working together can sort of start defining, maybe the national average is 30 days, but it's going to look different in different places. So that's where data science comes in. That's where these research networks come in. And that would be a great place for the Margolis Center to lead in terms of defining policy in a more like precision medicine type way, instead of it's not precision medicine, it's precision
policy.
Clinics. Yeah, precision policy. Yeah.
Great. Thanks, Eric.
I'll try not to compare health systems. But listening to the breadth of presentations over the course of the day was incredibly energizing, and how much is already happening that's relevant to this policy space. And to me, the common theme that comes out of all of these is really that everybody's trying to generate value for the system in health and healthcare. And I don't think that's always the case when people get together. And so, you're getting away from parochial perspectives, you're getting away from special interests, and I think there's we have the privilege and the opportunity to really represent a trusted third party of sorts for the system to bring resources, expertise in a very practical and applicable way. And that, I think, is the common theme I'd love to see the Margolis Center continue to build.
That's a great theme. So I heard some common messages there, and certainly building on some of the things that we talked about today. So now I've got to turn this around. So what question do you have, do you all have for the Margolis Center? What did you not hear about today? What seems unclear about how we should proceed? I know it's late in the afternoon on Friday, but put us on the spot a little bit. Who wants to start? Adrian.
Yeah, so let me start off with an easy question for you. So one of the biggest challenges is in the next year there's potentially could be a lot of changes or transitions, and so how do we actually take advantage of that? Because make sure that we're part of the national conversation, offering solutions, and so then whether it's President Trump or Clinton, that they're actually noting experts from Margolis raising this issue and bringing it to bear.
Yeah, that's a great question, and other Margolis affiliated faculty or team members out here, feel free to help answer too. But one of the things that we think is a real advantage for the way that we've set up the center, with a strong presence with policymakers in Washington and with some of the national convening that we do in Washington for state leaders or private sector leaders and the like, is we hope that it gives us a sense of where things are going. So I can't predict nobody can predict what's going to happen in this election particularly, but there's some things I do know. One of the things that I know is that payment reform is going to be front and center for either party, whoever wins the presidency, whoever is in control of the House and Senate, and it's also going to be a big issue at the state level, with more things going on where states are working together across their state purchasing, Medicaid. Dev mentioned some of the reforms that are happening here in North Carolina that are going to require a fresh outlook. So we will be up to speed on the policy proposals, debates and discussion there. As you all may know, a set of the Margolis faculty submitted comments on the recent MACRA regulation. I think HHS got thousands of comments in, and Dev, you read a lot of them, and you thought ours was one of the best. One of the best, all right. And we're just getting started, right? So there will be that kind of, that keeps us up to date. It lets us know about what's coming up, and there certainly will be other issues that where elections do matter. I think if Secretary Clinton wins, you can see kind of a continuation of the ACA, maybe with some new steps to try to make it a bit more attractive and popular with the middle class. Some of the issues that Peter brought up on making the choices more transparent are important. But as you know, one of the big challenges with the ACA and healthcare more generally has just been the cost of insurance and the limitations of some of the traditional approaches like high deductibles or narrow networks alone of getting people the kind of high value care they want. So in that case, I think our work is also going to be very well positioned. On the Trump side, the Trump health plan is 6 bullet points. If you go to his website, probably the most detailed is about importing drugs from Canada and Europe. But since neither candidate is really running hard on healthcare issues, I mean, Secretary Clinton's talking a bit about her success with CHIP in the 1990s, but not really talking about the ACA. Donald Trump has other issues that he's found, connecting much better with the public on. I think we're going to have an election next year that's going to be driven by other things happening. What's going on with the Republican leadership in the House and Senate. Some of the things that Paul Ryan has tried to pull together to propose recently. If Trump does win and there is a Republican House and Senate, even if there's not, and there probably wouldn't be a full repeal of the ACA, there would be a pretty clear indication of moving towards more state flexibility in how they deliver benefits. I think some of the changes that Deb was talking about in state Medicaid in North Carolina are big. Both the Republicans House and Senate and Donald Trump have talked about giving states more flexibility, something more like block grants. I know that's been a controversial area, but if you think about a lot of the reforms that you've heard about today, which involve much more emphasis on communities, on redirecting resources, not just for dealing with complications of health problems in the emergency room, but really trying to empower community interventions, community health workers, social services that are targeted effectively, that really start getting at those particular needs of particular patients who are out of compliance with their diabetes meds or otherwise are having costly health complications. That's going to require new kinds of financing. You're not going to get there with more fee-for-service and just a few add-on payments. So might seem like a sort of a different partisan outcome on the surface, but whoever wins, there'll be more pressure and more opportunities from switching to this. I like this personalized policy to support better outcomes for individuals, even if it means doing things that are a lot different than in traditional healthcare, and that means does mean changing the financial incentives and financial and creating that kind of financial alignment. I think has been a big theme today too, and I do think that there are just tremendous opportunities around better evidence. So as you all have made very clear, we've got tons of data in healthcare now, but data is not the same as evidence, and the kinds of stuff that we've talked about today I think are going to be relevant there as well. So appreciate any other Margolis affiliated faculty want to add to this in terms of things that we're thinking about and trying to anticipate as we head into 2017. So also say that we're providing some support for a number of other policy initiatives. Adrian mentioned some work that the Bipartisan Policy Center, which is very Congress-focused, is doing on issues like FDA reform and real-world evidence. Greg Daniel helped develop a lot of those policies along with Adrian and others. We're supporting an effort by the National Academy of Medicine called Vital Directions, which is a set of policy reform proposals for 2017. So we're going to try to accomplish what Leslie said. Be on the other end of that phone call when whoever it is that wins, we're at the top of that call list. Other questions? That was a good one.
I got one.
Yeah.
It's maybe a bit rhetorical. So when we see the totality of everything that was discussed today and the opportunity to test it, and the reality that everything is moving so fast, and today's work has to be done today, how do we find a way to sort of do all these things through a systematic method of prioritization and recognition of what you can, because there's only so many things you can do, so many things you can try, and we're still, if you will, graded on the conventional way of doing business. So how do we, again, maybe rhetorical, but maybe not, how do we get this work done?
Well, we've talked a lot about some of the challenges in getting data that's relevant to policy, and we are making some big steps thanks to leadership of people in this room around data from Medicare claims and other sources. But I think what your comment goes to is, you're making decisions in real time, and if you think it's tough getting data for research questions when you can wait a year or two or three to try to get the files to come in and clean them all up and everything. I mean, just think about what it's like on the front lines when you're being increasingly held accountable, trying to think about ways to actually improve outcomes for patients and lower costs with very often very limited data capabilities. And I would turn that back to people like Eric and others here who are, I think, and that's one of I think the strengths of this center is that we are, because we get to work at a place like Duke that is leading the world on data and analytic systems and real-world evidence, but also taking some of the leading steps and some of the leading thinkers on making data available for actual improvements in care. I think there's going to be a convergence there. We're certainly aiming for breaking down and reducing that distance between data used for research and data that's actually relevant for improving care and improving health. And actually, maybe I can turn this back to Leslie, Adrian, Eric. You guys have thought about this a lot, right? Anybody?
Has the answers.
That's all that Eric has the answer.
Eric's got
You know, obviously, you know, Larry's talked a little bit about, touched on building the infrastructure for, you know, the problem with, and maybe this actually brings up one of the questions that, you know, or, you know, things we might think about too, is that really accessing the data is obviously very difficult. So PCORNet's a good example of how we might do that as a model. But as we want to go deeper into, you know, accessing all aspects of the electronic health record, you know, our technology is not really set up to do that yet. And so certainly one of the things that we need to think about is how to support that kind of infrastructure. And then alongside with that is, again, policy always sticks its nose into this, and that, for instance, you know, HIPAA, you know, I wonder if we need to start rethinking that, you know, the notion of, you know, how we manage and protect, you know, patient data. Oh, Adrian's asking me to put my mouth closer to the thing. You know, I was just also sitting at my table talking with, you know, Robert Calderbank and Jerry. You know, we were talking about differential privacy. So Apple's, you know, pronounced that they're going to use this new technology to actually access, you know, individual iPhone data by injecting, you know, a certain amount of noise into it. So can we actually help, you know, inform new discussions about HIPAA, for example, so that we can access the data by even doing things like injecting a little bit of noise into the data so that we can actually look at it in aggregate and be able to generate conclusions from it. And, you know, of course, there's newer technologies like homomorphic encryption and things like that, where in theory you could even run, you know, an equation on completely encrypted data. But we need to have this conversation, because if we're going to use all this data to, you know, generate evidence, right now the data is pretty well locked up. PCORNet's an example how we might unlock it, but we need to be able to do that at a national scale.
You'd like to see Adrian or Leslie if you have comments on this. And is Zubin still here? Oh, okay, Zubin, going to you next, so get ready.
Yeah, so I just want to pick up what Eric was saying, in that, like, one of the things that we can do here is help break these silos in terms of what's a policy issues, because there's right now a ton of confusion of what is possible, and that's partly because of lack of clarity, but also there are some problems with current policies in terms of how they were developed essentially in the 1990s, and we're well beyond that. And so that needs to be updated here. If you survey patients, they actually want their information used. They actually think we're actually using it, but we're not. And so every time they walk through the doors, unfortunately, you know, we're actually indirectly betraying that trust, because they think that we've learned from the previous patient that just walked through the door. And that's where I think you know, we can help drive some policy changes to allow that freedom of use in an appropriate way.
You know, a point, maybe this is picking up on something that both Adrian and Eric said, but we have a unique opportunity to show how to do this kind of work. So we have responsibility for making PCORNet work. I'm sorry to remind you of that on a Friday afternoon.
Yeah.
We have that responsibility, and we will do that. With that, though, comes a tremendous opportunity for people at Duke to be the first people to figure out, how do we use that resource to answer critical policy questions. I believe, like, showing people how it's done, that's the real opportunity here.
And showing them the benefits, and it can be done
Absolutely.
while protecting their privacy
Absolutely.
and protecting the proprietary interests of
the health
or
systems
health
who've-
plans
yes,
or
that's exactly
others.
right.
You know, thinking about
I
all
would just
together.
label that leadership by example. That's what we want.
And related to this, one of the, we got one. One of the things that we did recently with Zubin Apin, you don't know Dr. Apin, he's a cardiologist here and has been involved in a lot of the work at DCRI on better evidence, and including evidence that's relevant to policy. We recently held a roundtable at Stanford, so with some other collaborators, on issues related to digital health evidence and policy. This was one of the big themes that came up with you know, this combination of patient control of data potentially being maybe a some people view it as a threat, but maybe really an opportunity for getting much more timely and complete and meaningful data for policy and other healthcare delivery purposes, but also some of the challenges around HIPAA and maybe the need for a new kind of regulatory framework for data that could be controlled by a patient, maybe not used directly in care, but could be used to support that patient's decision-making, connecting them based on their own preferences with different kinds of providers, different research opportunities, but more generally, a lot of really innovative potential in terms of digital health. So I wondering if you could comment on this general topic as well. Sorry I put you on the spot.
No,
but
no,
it's,
thanks, Mark.
That's the nature of this center.
No, thanks, Mark. This is good. Pop quizzes all around. I thought the event at Stanford was an excellent opportunity and maybe highlights what the Margolis Center is going to do in a lot of ways, which is to bring together a multidisciplinary group around some of these common issues like digital health. So in the room for that, we had academicians, we had payers, we had people from the tech industry, both small and large, who really had tackled these problems over the last couple of decades. And I think they illustrated a lot of issues, one being evidence generation that's needed in the digital health space. We have patients and consumers who are using solutions out in the marketplace which we are not sure if they're safe and effective. There needs to be some more work done around that. But as you mentioned, Mark, there was a lot of commentary on the regulatory framework, the HIPAA issues that we need to solve, maybe even before that. And I think what Eric had brought up in terms of how we might be able to do that, take some of these large data sets, I think is a very important next step. The other piece of this, I think, is really thinking about how do we use PCORDNet maybe as an anchoring framework, but how do we involve patients directly in the data generation and answering some of these questions. The patient-powered research networks, I think, is a very important aspect of the tentacles that might reach out of PCORDNet and a way for patients to be able to contribute their own data.
Great, thanks. Other questions?
Well, it's the first question to follow up on this and perhaps try to be a bit contrarian and provocative. Right? While it's important to be more effective in managing and creating these data resources, right? We have lots of opportunities today that we don't need better data to know what needs to change. Right? We don't need better data to show how misaligned our system is. So while we put time and resources into creating these structures to make better use of data, how do we also take advantage of the near term where there are opportunities where all the evidence exists and it's either political inertia or other barriers, not the data, that are actually preventing us from seeing improvement?
Yeah, great question, and a lot of that came up today. Christian, as you know, we've been working on a framework to try to apply that internationally, looking at regulatory and environmental contexts and feasible ways to change those. One of the things that I've seen in the international work that we've done is, number one, everybody's facing the same problems. I don't care if you're a fully developed healthcare system with universal health coverage or a less developed country that's just struggling to get access to basic drugs and primary care. We don't have efficient mechanisms in place to do that really anywhere. And one of the main, I think, findings of the work that you've been leading so far that we're really hoping to expand on is to show that there are lessons that can be learned from a wide range of countries, not only about particular innovations, but about the policy frameworks and political steps to make it possible to do things differently, to deliver care more efficiently, to make populations healthier, and to think about health policy and overcome political barriers in new ways. So, these are hard questions. I don't think we've got all the answers, but boy, we've got a good group to try to get there together. So I know we've got some questions out here as well, so please go and get a microphone out. And I would like, for those of you who are here, have stuck with us today, if you've got questions, things that you didn't hear about, things you'd like to follow up on, just in the spirit of the way we turned around the panel a little bit just now, I'd like to hear from you all.
First of all, for 6 months on the job, to have created these work streams will be absolutely a fire hose of data to inform policy. I'd like to think a year or two after that. In other words, what do we do not only for elected officials, but the electorate as far as education and changing minds. The new editor of Science, as well as the whole AAS, is really focusing on, how are we going to bring the message of science to our country to help elected officials make hard choices.
Yeah, we have had a lot of focus today, you're right, on policymakers and evidence that they can use, but there was an undercurrent in that. Peter Ubel talked about it, I think some of you on the panel have just been talking about it, that really, if you want to get the attention of policymakers, that the best and most proven way to do that is get the attention of the public. Now, there are lots of ways to do that. Not all of them are steeped in strong and compelling evidence, but maybe I could turn to some of you who have been dealing with this. There's certainly been an issue with PCORI and trying to have patient-driven approaches and patient-engaged research. And did Greg have to catch a plane? So no, there's Greg. He talked about some of the patient-led efforts around drug development, and then value in getting public support for shifts towards value rather than volume in use of technologies in healthcare. So,
So I think that's one of the kind of hallmarks that we're trying to actually drive is actually, as we go along, when there's opportunity to actually partner with patients and patient groups, that'll be more powerful, because then, as results are coming out, then we're able to actually have that as really prime dissemination channel. And so that is going to be something. And so we've actually, we've talked about this. Once we see those things come out that's needed, we can bring together multiple patient groups onto Washington and also to educate their communities. And so through a variety of networks that we've established, we can do that soon.
Yeah, Leslie?
Yeah, just one point. I think there is a science that underlies patient engagement, right? And how do we actually do that? Engage patients and then translate into the community and teach. And that has to be really an essential part of what we do. Develop those education programs that train the scientists who do patient engagement.
Yeah, I really think we're just scratching the surface on this, but if there is any place that's paying attention to it and getting it and trying to get it right, it is Duke. I mean, as you just heard from Leslie and Adrian, this is kind of a hallmark of the efforts around building these big research networks. And Greg, maybe you could talk a little bit about the work that's going on related to patient-focused drug development. And I think Jillian touched on it earlier in value frameworks that are not just what payers think or what pointy-headed policy experts think, but they're really driven by patient perspectives there as well.
Yeah, I would say there's been a lot of focus on sort of the concept of patient-centeredness in drug development over the last 2 years since FDASIA 2012 and the last PDUFA reauthorization, which included the requirement for FDA to build this patient-focused drug development. And so what the FDA has been doing is bringing in patient groups to better understand what their needs are, what their concerns are, what the outcomes that are most meaningful to them. And that's been great, but it's been okay, hold it up. It's been limited in terms of what you can do. The FDA is a big ship, and it's really hard to move and to be nimble. And so I'd say we're part of the way there. So at least the agency has sort of mechanisms for patients to come in and talk about the outcomes that are meaningful to them. But I think taking it to the next step, incorporating that into an actual new process for the agency, or actually changing the way that they look at the evidence to approve drugs, is a different thing, because we're limited in the ability to really know how to collect patient preferences and include those in the regulatory process, and then how to take that and incorporate that into more of an objective, quantitative way to look at benefits and risks that matter to patients. So those are really complicated things to do, but it's also an opportunity for our center to start working more closely with patient groups. We've already been approached by several different patient groups that actually have funding as well to look at our center and view our center as an opportunity to bring the right people to the table, not only FDA, but the scientists, the other patient groups, and really get more structure and more ideas about the innovative and best ways to measure patient preferences the right way, and to include those into the regulatory clinical development process.
Yeah, and I just extend on that. We talked a lot today about value in healthcare, value in payment reform, value in benefit designs, some of the work that Peter was discussing. I would go so far as to say that none of that is really going to get anywhere in terms of policy impact unless patients really do buy in, and there still is a big gap between what I think a lot of evidence would suggest is good for healthcare and maybe good for payment systems as well as good for regulation and how the public sees it. So I think that absolutely has got to be, and thanks to the resources again that we have here uniquely at Duke, that can be a core strength of this program as being a truly patient-centered approach to health policy. Great question. Others? Yes. Well, we'll get you. Here you go.
This is probably I'm Jerry Ryder from Statistical Science and the Information Initiative at Duke. This is probably more a question that's masquerading as a possible suggestion. So one of the
that's what we're looking for. What did you not hear?
One of the activities in Washington that those of us in statistics interested in policy are sort of following is this Murray-Ryan Commission for evidence-based policymaking in the federal government, and so I'm sort of wondering if the Washington folks with Margolis have had any contact with commission members. They've recently been listed, and if not, then a suggestion would be to prepare a 1 or 2 pager to send to them so that they know the existence.
Great question. I'll take this one if you guys want to add to it as well. But this Murray-Ryan Commission grew out of a push for answering the question of why isn't more evidence available to drive policy decisions around, say, the budget impacts of policy reforms in a wide range of areas. It's not limited to healthcare and health policy by any means, although this is where most of the money goes. Why isn't there more, not just why isn't there more evidence being generated, but how come the evidence is generated isn't more relevant to policy? So we have been involved in that. One example of this, aside from being in touch with the staff and members, is one of our early grants from the Arnold Foundation. I think you're kind of familiar with. This was Arnold Foundation has some of its key staff, former staff from OMB and elsewhere who are, they're not there accidentally. This is what the foundation is really about, is having better evidence from, in their ideal world, I think it would all be from well-designed randomized clinical trials. In the world that we live in, for many relevant health policy questions like payment reforms, that's just not going to happen widely. But how can we develop better evidence faster that's relevant to policy? And one of our early center grants is about it's partly convening, bringing together different experts around the country who have worked on issues like issues related to payment reform and how we can learn from what's been done so far. And as Don knows, since he's very much involved in leading this effort, also ways to bring down the cost of developing evidence, as there are lots and lots of payment reforms being implemented all over the country here at Duke too, and we're not learning that much from them. We haven't yet made this kind of great infrastructure we're trying to develop here very relevant to people who are, as Deb was saying earlier, having to make decisions on short notice, having to adjust these programs along the way. And to that end, there's been a lot of interest in, I know one of your areas of interest, Bayesian statistical methods for policy. Are there different levels of evidence that you could think of for payment reforms or other policy decisions that are very relevant to this commission that could help make some of the available evidence more interpretable? Is there a framework that we could help develop that would encourage both more development of relevant evidence for policy and more confidence about interpreting it when most of this evidence is coming from diverse populations under far from ideal, experimental methodologic conditions. So, and the short answer is yes. It's very relevant to the work that we're doing, and I hope, given all the potential here for pulling together data and doing good analytic work, we can actually be a model for what that commission would like to see in a wide range of areas of public policy decision making. Others, you guys have tough late afternoon Friday questions. Steve, good ones.
One of the intrinsic conflicts that we have in anything related to health policy is the ongoing conflict between the microeconomics of a health system and the macroeconomics of the national healthcare system. So today we talk about policy, federal policy, state policy, and those are, important items. And we talk about patient-centered care and the importance of changing our health systems for health to improve patient-centered care. The endangered species that's in between there are the health system CEOs, the department chairs, people who have fiscal responsibility for bringing their departments and their health systems at least breaking even, hopefully far enough in the black to be able to reinvest in research and that. What can Margolis do to help that endangered species figure out how to navigate these waters? Because, at the end of the day, a cynical view could say every time we do a value-based health innovation, the margin of a department or a health system decreases, and that's less money to reinvest back into innovative healthcare. So how do we address that? I don't hear much being said about that.
So Devin, I come to you in a minute on this too. You talked about like endangered species. One of the nice things I like to think of about dealing with public policy and humans instead of natural selection is that evolution can take place within the same individuals and the same systems. It's not just a matter of the old ones dying out. And one of the things that I think is most important about where we go forward from here, and a lot of the health policy reforms we've talked about today, especially the shift from volume to value, the new payment models, is paying as much attention, if not more attention, to what it takes on the ground for healthcare organizations to change and do well, and not only succeed, but do well and be confident moving into these models, as it is to developing the evidence on which of these payment reforms seems to work best in which situations. So this is kind of a link to Jerry's question and yours. I really see them as sort of two sides. Analogy we've been using lately is in some collaboration work that we're doing with Mike Levitt, former Secretary of HHS, around improving healthcare competencies. It's kind of like skiing, right? You need the policies to change, but if the healthcare organizations aren't moving along with them, you're just gonna fall over, or back to your analogy, certainly not have success. And if you look at some of the recent payment reforms that have been implemented, even Jeff's been working a lot on the Medicare Shared Savings Program. Only about 1 out of 4 of the organizations in that program have actually succeeded in terms of measurable improvements in the performance measures in the shift towards a population health focus and measurable reductions in cost trends. And that kind of rate does not really inspire a lot of confidence in the health system or in the public that gosh, we should just race forward with these reforms. So one of the areas where we're going to be doing a lot of work, and Jeff, you might want to add to this too, Jeff Dev, is finding, developing better evidence nationwide on what works, from not just from the policy standpoint, but the flip side of that. This gets back to Mary Klopman's comment earlier about management and leadership in healthcare now and going forward isn't just about doing a good job with your current financial models, but being able to think ahead about what's coming and what it's really going to take to develop the capabilities to succeed in these new and emerging payment reforms and delivery systems. So this is not easy, but it is a skill set that I think we can bring both here at Duke and through collaborations with places like UT Dell. I mean, Mike, you all are struggling with this too. Conceptually, you've got a good idea of what to do, but that's really different from actually doing it in the real world. Every healthcare system in this country is struggling with these issues. Deb, you want to?
So I think Steve, you asked rather the toughest question, this idea of not doing something and not generating the revenue by doing, and the potential of getting some fraction of that revenue later on if everything else works out okay. We're doers. I mean, healthcare providers are doers, and getting doers to become not doers is a tough thing to do. It's part of its philosophy, part of its evidence, and part of its pocketbook. Sort of like the triple aim, if you will, of how do you get them to do things differently. Because, the thing is we can show as much evidence as there is out there, but if there's a philosophy of a provider that says, I'm going to bypass evidence for good reason, you have to ask yourself how much of that is guided by reimbursement or any of those other things. I think our real opportunity is the reality. We're in a major growth area in the country. And so to the extent that we don't do where it makes sense to not do, there are a lot of other people who need stuff done to them, the right stuff. So I think that's where our real opportunity is to realize that, and you see this in cancer as well. I mean, we have some wait times to get into some of our cancer clinics that we are really challenged to shorten. We have wait times elsewhere. Our hospitals are full. I mean, we have a real opportunity here to think about all these policy things and not compromise in a way that other areas where keeping patients in the hospitals, clinics full, and so forth, and implementing these value-based payment models may compromise the bottom line. So I think our opportunities now to do these kind of neat new things.
Jeff?
I would just like to
Okay, go
say,
ahead,
cancer is the worst offender, particularly in the cost of our drugs. And so talking to Gregory, this is an area that we would love to be engaged in this conversation, but it's complicated because the margin on cancer drugs drives a large part of the ability of a university's medical center to engage in medical. And
I'll just add that if we look at in one of our populations in Medicare, one of our biggest challenges, the highest cost is in patients who become our patients through the attribution model. And a good portion of them are higher cost patients, and they die within 6 months of becoming our patients. But I think what's embedded in there is the reality they become our patients because they come to Duke, because we offer phenomenal cancer care. So it's just not the revenue versus the shared savings, it's the patient preference. And then we have staff here who have done phenomenal things, and we'll use cancer as an example, but applies to heart and everywhere else, who do phenomenal, great things and will continue to do that, but we need those sort of patients coming in to do that. So I think it's almost like a four-way kind of balancing act that we need to figure out.
Right. Comments on this?
Here.
Sure. I mean, I think I'll just add, that's sort of the motivation for a lot of the work that we're trying to do is really, dig down beneath within the systems and understand, what systems have been able to do well. So at least bringing that knowledge, it'll make it easier for to kind of pool and develop those innovations. And then I think, secondly, just kind of getting back to the point when we look at, what's the alternative? The alternative isn't just to continue on the path we're on. The alternative are more savage payment cuts, changes in benefits that are going to have a much bigger impact. So I think that's, that doesn't really get to the question of, how do we make it happen, but the stakes are going to be higher and it's going to have to happen.
All right, I'm going to take this as actually ending on an optimistic note because challenging as these issues are, what I'm taking away from today is there is no group better positioned to take them on than the group that we've assembled here collectively. We are just getting going with the Margolis Center, so this is a strategic plan, but I hope it's clear that this is a strategic plan that is still that's the view from, so next July 4th, that's the view from the new Margolis DC offices. But before you go on to your fireworks this weekend, I just just want to thank everyone for the time and the effort that they've put into getting us to this point, and to thank everyone in advance. We still have a long way to go in terms of engaging patients, in terms of showing not only which policy reforms really work, more efficient evidence development and interpretation and applicability, but more engagement of patients and the public in that, and also more engagement with health systems to make these very difficult changes. I like your new version of the triple aim, Deb. So we have a long way to go, but I can't think of anyone, any group that I'd rather go on this journey with. This is exactly why when Bob and Sally and Jean called about getting this underway, this is exactly why I was so enthusiastic about undertaking it. And I have to say that the resources here at Duke, I mean, we're bringing some with the Margolis Center, but boy, there's a tremendous amount to build on here. We're going to do these kinds of convenings on a regular basis. They're going to probably get more focused, not just on the general strategic plan, but on specific challenging issues that we're undertaking, like the ones that you all have brought up this afternoon. But in the meantime, keep in mind that we are up and running. We're not going to be visible and big in public probably for another 6 months as we get more of these projects further underway and show that we really do mean business on delivering on some of these ideas. But while we work on that together, I can't think of any group that I'd rather work on these issues with, and I can't think of a better opportunity to do it than with all of you. So thank you all very much for the support for the Margolis Center so far. Have a happy 4th, and we're looking forward to a great journey ahead. Thank you very much. Thank you guys for doing